I'm waiting for permission from my intrepid leader, Aditi LaRay. Okay, she's giving me the thumbs up. Hi. Welcome. For those of you who don't know me, I'm Michael Romali. I run the public policy programs here at Philanthropy New York, so it's my duty and pleasure to welcome you here to Philanthropy New York if you haven't been here before. I hope you come often. This is going to be a really great program. Oh, where's my introductory notes? Okay, so this is a program of the Health Policy Working Group of Philanthropy New York, as you figured out, which is, if you're not familiar with it, is a group of funders from all over the map who are interested in health policy. They might not be specifically focused on health policy exclusively, but they are interested in health policy. And this program, as you may recall from when you signed up, was called 5 Big Trends Affecting Philanthropy, blah, blah, blah. But we, little bait and switch, we actually have 7 trends that we'll be talking about today, but I didn't feel like going back and changing the title because social science research says people can't deal with more than 5 choices anyway. So we'll go with 5, and we'll actually talk about 7. So before we get started, and I introduce our wonderful panelist speakers, our debaters and talkers. And I want to thank a couple people who are on the planning committee of the Health Policy Working Group Program Planning Subcommittee, who have really been helpful in putting this particular program together. Amy Schechter, who just walked in from New York State Health Foundation, Debbie Halper from United Hospital Fund, and always Rachel Pine at Altman Foundation. There are lots of other people on the committee who are helpful in other ways, but those 3 were particularly helpful on this program. So thank you. Okay, hi, and welcome to everyone out on the live stream. For those of you in the room, we are on live stream, and you probably noticed that this is not making any sound here in the room. This is not for amplification, it's just for picking up the sound for the live stream. So when we get to the Q&A portion of our discussion, we'll be passing this around and we'll ask you to speak into the mic and identify yourself for the folks who are out in the world. So, hi. This was kind of conceived as a program, an open discussion between Jim and Jim, and we thought, oh, 2 guys talking up in front of the room, you know, it could use a little more pizzazz. So we said, hey, let's bring LaRay into this. So LaRay is going to interrogate these 2 guys.
I think we said someone who really knows what's going on.
So let me just let me start with LaRay. And LaRay is the Senior Vice President at the Corporate Planning, Community Health, and oh my God, you've got a long title, and Intergovernmental Relations and Corporate Officer at the New York City Health and Hospitals Corporation. And as Jim just said, she knows more about these 7 trends than just about that we're going to be talking about than just about anybody in New York. And we're really pleased to have you with us. Thank you for coming. Jim Knickman, who is the co-chair of the Health Policy Working Group. He also sits on Philanthropy New York's, is the co-chair of Philanthropy New York's General Public Policy Committee that sets up programming, legislative activity and stuff for our organization, and is on our board of directors. So he's a big important person, aside from all of his other affiliations. And of course, Jim Tallon, who is highly esteemed all around the city and all across the nation for his role leading the United Hospital Fund of New York. So with that, I'm going to hand it over to LaRay, and she's going to say a little bit about how we're going to proceed and get us going.
Thank you very much. As was said, rather than just 5 big trends, we're just going to talk about big trends, and there's a list of 7, ranging from the issue of the day, insurance and enrollment and coverage, integrated delivery systems, payment reform, hospital, and I would say the healthcare delivery system sustainability, quality and patient safety and patient engagement, and healthcare disparities. And they really are all of one. And I think the other, if not a big trend, but what we all are facing is that there is a major, the environment is in such flux that, if anything, the biggest trend is that there is huge change. And probably another big trend is that there are great expectations. And so I'd hope that my colleagues, as part of the panel, will be able to speak to not just these 7 issues, but those 2 other issues. Because often with major transformation and great expectations, there is also great frustration, there's great fallout, and sometimes great disappointment. So I don't want to be the bearer of bad news or put this in or have a negative pall. What I'm saying is that those of you around the table and those who are listening in, I think we all need to look at all of these trends and look at their interrelationships and really step back and look at, from your perspectives, what role might leaders in philanthropy play so that we don't have big frustration and big disappointment at the end of the day. So the way in which we're going to approach this is I'm going to ask the 2 Jims to start and to take an issue or a trend. And there are some questions on the screen, and I will add some questions, but maybe on the first big trend related to insurance enrollment and coverage. I kind of think that enrollment looks sort of wrong, but you know, there may be a, it's okay. Something's missing, but in fact, some ones are missing from this big trend affecting philanthropy and frankly, healthcare transformation. So I would frame the question as to who's not included in this big trend, and what are some of the challenges and opportunities for those who are not included in the area of enrollment and coverage. But that's my question. However, gentlemen, you can start where you like. Jim?
Yeah. So, we start with the state should feel really good, and the city should feel really good about the success with Obamacare, and we are a state that did very well, I think, in enrolling people. And so there's about 1.5 million people enrolled in insurance, either through the exchange or Medicaid. Probably 80% of them, somewhere around 80% of them, didn't have coverage before this happened. So a lot of it is new coverage. I know, so it's not just churning; it's new coverage. That's really exciting. We like to say, I should note, by the way, that LaRay is also on our board of directors at the New York State Health Foundation, our most important role in life. And we really value having her there. But there were times when when we first started worrying about coverage at our foundation, we would get excited if we had a program that got 1,000 people covered or 500 people covered through some Chamber of Commerce program or something. There was so little opportunity to make a difference. So this 1.5 million people is such a great victory, I think. So it's great. That's there's still 1 million people uninsured, to get to your question. So there's still a lot to do to improve on that. And I think that a third of those people who are uninsured, at least, and we'll get to this later, are undocumented immigrants, but there's some good signs even there. But, and then I think there's still some people who are eligible for Medicaid that have not come forward, who will only come forward probably when we have a need for a hospitalization or something like that. And then there are still the invincibles who are, not stepping forward when they could.
The trend is a very positive one. And if Kathy Regan is here from the Commonwealth Fund, and Commonwealth has been monitoring this nationally and internationally for a number of years. So we would look at, in New York, even a good state in terms of coverage, at a double-digit uninsured rate, maybe up in the 15% range of under 65 folks. Even with our Medicaid program, in which we had the coverage, but with some enrollment complexities, had a lot of folks who were eligible but not enrolled, and that's a body of work that existed and Jim and I have collaborated on for many, many years. So the Affordable Care Act happens. and it makes a difference. And Medicaid reform happens at the beginning of Governor Cuomo's first term in the first year, and New York doubles down on its Medicaid program. We now have 6 million people in the state covered through the Medicaid program. So we're seeing a lot more folks, and the reason this is critical is that having the ability of a person to have insurance means that we can then start to think about how that individual, their family, and their circumstances enter into a healthcare system, and we can build the incentives and the controls and the and the responsibilities into that. We're thinking less about making direct subsidy payments into a system for people who have no coverage. So you start to think about people more likely to be insured. We're going to be down to single-digit percentages in New York. We're probably there, probably close to there already. And then that insurance system is giving its incentive to think about how money ought to flow from the public programs, even and the private insurance carriers, into the service delivery system. And we'll get to all this, but it all goes together. The service delivery system is integrating. The people who pay are thinking about different ways to send incentives into those who are delivering care. There's a big world ahead that if I were to say, what's the uncharted frontier here in terms of the work we'll be doing, it's how do we get people to kind of understand these new sets of relationships. And then there is just ubiquitous information technology. That's the thing that really changed a little less than a decade ago. Real-time flows of information about what's going on. So if you think about payment, service delivery, consumer patient engagement, and integrated information technology, this is the first part of it. And we're moving in a good direction here. Let me just close with an asterisk. There's still some political opposition nationally. We don't hear it so much in New York. And maybe the other night, people weren't denouncing Obamacare as much as they usually do because they were busy complaining about other things. There is a court case that will be argued in March and decided in June about just 4 words in the law. And it's this question of whether the subsidies, the IRS tax subsidies that are built into the exchanges, the language of one section of the law says it can only be paid through exchanges, quotes, established by the state. Now, 16 states plus the District of Columbia have established their own exchange. 34 are relying on a federal exchange, and the plaintiffs say that as what the case to the Supreme Court says, IRS, you may not provide subsidies to those estimate most recently 9 million or so people who are getting their coverage through the federal exchange. It's going to be a 5-4 court. Who knows? If the court rules on that point, of course, the Congress can come back in and fix this over a weekend just by taking the 4 words out. But this whole thing could flip into crisis in June. We in New York, we've established an exchange, so technically we're not at risk. But the broader superstructure that's into the Affordable Care Act, we could be back into another debate about the future of the Affordable Care Act when most all of the other challenges have fallen by the wayside. So good news, positive news. It's integral to everything else that's happening. And we'll get to the question of who's left out if you want to spend some time on that in New York. But good news, and you keep your eyes open because watch the court decisions carefully.
But Jim, both of you mentioned, with notwithstanding all the great news, and I think those of us in New York can be really proud of what the state of New York has done, and the partners that have worked with the state of New York in terms of the health exchange and just the sheer number of individuals enrolled in both insurance and in our public insurance program, Medicaid. But you both mentioned that there are still some challenges in terms of getting the information out, helping people to understand who have not been insured before, to understand how to really get the most out of now having insurance coverage. What are some of the things that, you know, in the horizon might your organizations and others, what might they be considering?
I'll take this one,
Sure.
Jim. As the state set up the exchange, it created a whole series of relationships with people, including individuals, organizations who are paid to help. And so there's an online access, but you can get to somebody who will literally walk you through this. And I've now, heard enough people and their personal experiences that we've had a pretty good run with the New York Exchange right from the beginning. But I think that activity is working through. Now, you still have to motivate people to come out, and that effort needs to keep going forward. We're into a second round of enrollment now, between now and February 15th. One of the questions, the immigrant population, is going to be a target, one, because of cultural isolation, language isolation, and in some, a portion of our immigrant population in New York, a lack of adequate and legal documentation. Now, recognize the New York Constitution on this subject actually doesn't provide rights to citizens, it provides rights to residents. And that's very important. So there is a constitutional right in New York to the Medicaid program if you are legally a resident of the state, even if you're not a citizen. I think what's going to happen, and I would hope, with the president's executive actions, both what he has been done and what he is in the process of doing now, and I don't assume that anything that Congress does is going to effectively repeal his activity. We'll see what happens. More and more individuals are going to have some basis in law to claim a legal standing, and therefore in New York will be eligible for our Medicaid program. There are income tests that have to be met. We have always run the child health insurance program in New York based on residence. So there will be a core of people who are truly undocumented, not met and not supported by whatever actions can be taken on the executive side in terms of immigration. But in immigrant populations, working with the organizations that are engaged in those communities, I think we're going to find more and more people actually will be eligible to participate in some of our programs. I'm not sure if someone is truly undocumented and therefore doesn't have any security in the law, fears deportation. I'm not wild about the notion of thinking that I can sell them an insurance card or sell them an insurance policy. There's a whole thing about who are you? But there's some ideas, and we've worked with some of the other organizations, some at this table, to think even about how you could do that. But we're going to find in the immigrant population more and more folks who are going to have a standing to be here, at least temporarily, and that will qualify them for existing programs in New York.
Yeah, and Jim, and before we leave this issue, because it's such an important issue in terms of that, having that coverage and insurance, there are a lot of individuals who have signed up for insurance, but who made their decision based on price, right? And they have, and with high deductibles of some of the products that they've purchased. What are your thoughts as to what might happen as, because many of these folks haven't used their coverage yet, as they do enter into the healthcare delivery system and they see that sticker shock as to what they need to pay out of their pocket?
Right. Well, I mean, first, I think a lot of issues here. I think there is work to do to make sure people are using services, and some of the early data suggests that use is up among the insured. They are using services. That's a good sign. And always the best way for people to learn is through their neighbors and their family. But there's probably roles for philanthropy to help, especially for immigrant groups and others who are more vulnerable. But in terms of in some ways, this issue of the adequacy of the coverage, it's going to be a big debate over the next 4, 5, 6 years, I guess. Is that these policies do have high deductibles and high co-payments. And that's how they kept the price down. I must say that that these co-payments are subsidized for people, what is it, about below 200% of poverty or so. So, the people who are near poverty are getting their deductibles and co-pays, a good portion of them paid. So in some ways, again, going back to the State of the Union message, we're talking about not the poor who are vulnerable, but the working class people with a family of 4, making $38,000 to $100,000 are facing high deductibles, and we'll have to see how that is. I know personally a lot of people who have been shocked at how big the deductibles are and say, the vast majority of people will never touch their coverage. They'll be paying deductibles the whole time unless you're really sick. So that's one that we have to debate as a society. I think that maybe it's okay for healthy people. I really worry about people who are chronically ill and are going to have to pay that year in and year out. I call that a tax. Not a deductible if you have diabetes and you're paying that. So I think that's one that we need to face. The other issue, of course, is the adequacy of the networks. Can you get access to a provider? And a lot of folks have been complaining that there aren't enough providers in these networks. And remember, there's 2 issues: is somebody in the network, but then do they have an open panel? So there are a lot of providers who said, yes, I'll accept all this coverage, but then they say they have no space, so there's less people than it looks like there are on paper.
Or long waits.
Or very long waits, exactly. And so I think that's an issue that we have to face too. And it's a complicated one because I personally, I'd like to see the market work this out. I think that if an insurance company has a terrible network, they're going to lose customers. But I might be more enamored with market forces than everyone. But I think that I do. The reason I would like to see the market work it out is because I think narrow networks are going to bring healthcare costs down, but they have to be adequate narrow networks. And so I think we need to work that through. I'd hate to overregulate it right from the start. I do think we need more transparency about the networks. I was saying to my staff that somebody needs to do a secret shopper type of analysis and say, gee, if you're in Empire, how hard is it to get an appointment versus if you're in Health Republic or so on? And I think that type of information that would be made transparent would scare the heck out of an insurance company that failed that secret shopper test. But anyway, I think those are some of the adequacy issues.
So before we move into next trends, and I'm not sure if this is part of the rule, but because I saw a lot of heads, sort of affirming what folks were saying, I'd really like to ask some folks around the table, what some of your thoughts are on the issue of insurance and coverage, just briefly. That way, so it's not 3 folks sitting at the head of the table and just talking at you.
Good idea.
Desire.
Well,
no
thank
good
you.
things goes unpunished. You look and you smile, and therefore we put a mic in front of you.
Thank you. I'm Nora O'Brien-Zurich with the John A. Hartford Foundation. So, we focus on the older adults. So, and the duals. So we're very familiar with that, and what you're giving us is information really on those that are not Medicare covered as well, and the duals. So this is really new information for us, and it's opened up a whole different world of looking at this because, of course, those who have the duals, they've got the Medicare, and their premiums, their deductibles are pretty much static over time. So I'm just wondering, as we move into more of the vulnerable population and we're focusing on the duals, we're going to be facing this more and more, those with just the Medicaid coverage and the immigrants. And so just wondering, what is it that we should be considering then on who to work with in making sure that we, on the policies and the programs that we're doing, that we're including those people that might be ineligible or might not be able to be eligible or meet the deductibles, and then what would happen in being able to get them to be covered?
I'll just say a little bit, and Jim should jump in. First is the duals are an interesting population in New York because they are going to be moved to managed care more and more, and so that's a challenge of itself, and you'll have all these adequacy of network issues and things like that. So I think that that's a concern. Surely, in terms of resources around the the Medicare Rights Center does a lot of work on this issue. We've supported them to do some work. The Center for Healthcare Strategies, who's in New Jersey, but they have done a lot of work in New York, are all over this issue. So I think there are some resources for foundations to use, and there's others, but people who are expert on this issue and are worried about it. So.
And not violating the solicitation policy. I mean, this is what we do. Jim and I are two organizations, the Health Foundation and the United Hospital Fund. And so we're watching the system all the time from all of these components. And Jim mentioned a couple of other organizations, the Men in the Medicare Rights Center, long time in its specific advocacy on Medicare. Just got to step back and look at the picture. Over the next 20 years, we just get a lot more people who are eligible for the Medicare program. I am already enrolled, and it was a shock the first day I was in a policy discussion and said, "We're talking about me." And remember, that population doubles. Okay, so long-term play, we get more older people. We did a couple of years ago get down inside this, and we had a surprising number. I'll forget the number, but it was in the higher single digits of older people in New York who weren't eligible for Medicare. And people, in many cases, interrelated to immigration where they didn't have a work history. So that's a. And then looking, some of them are going to, because of income levels, meet Medicaid eligibility. Often what's going to trigger the Medicaid eligibility is going to be chronic illness or a long-term care stay. And, the state is starting, as some other states are doing, to try to think about how to coordinate these two federal programs and to move on with the dual demos. What we've seen in other places is it's slow to get these things started. We'll have our own experience in New York. We'll follow it very, very closely. In the end, theoretically, it's clearly the right thing to do to be able to coordinate the benefits of the two programs. But I think it's what's the total picture? What do the numbers look like in New York? Who are the subsets of the population that you want to work with? This is a really engaged working environment in New York. We'll get to it in some of the other questions. That's really where I kind of wanted to start. The insurance thing is changing. The service delivery thing is changing. The technology is changing. And these are people who are available and work on this stuff every day in New York. This is a very engaged environment. And glad to help anybody find the roadmap that lets you get the questions answered that you need answered.
And I would just add to the organizations that both Jim's mentioned. I would say that you also want to be reaching out to those organizations who actually work with individuals who are disabled, for example, because that population group will be a large segment of this group. And so to get the perspective from those consumers' viewpoint as to, as Jim said, the coordination of benefits and what's the services that people need to be included in a FIDA plan or for those folks who are both Medicare and Medicaid, and by virtue of their disability or long-term chronic conditions being considered duals, and also get the more ideas about what the challenges are for those individuals who have not had a long work history and therefore not Medicare eligible. So other comments, questions before we move to our second big trend?
Child Health Plus, what are the prospects with that program, and how is that going to affect healthcare?
Bob, you have to get a microphone.
Say it again.
Asking about Child Health Plus.
I'm actually, fairly a good question and an open debate in Washington. If I am recalling, the child health insurance program is authorized through 2019, but is only funded through next year, right? Or even the end of 15, right? One of the questions is, well, you don't need it anymore because now you have the Affordable Care Act, but it does have a more comprehensive set of benefits for children. I think in New York, we would be well advised to keep a focus on child health insurance. I hope Senator Rockefeller, before his retirement from the Senate, was really out front on this subject. I'm not sure what the lay of the land is going to look like in Washington this year. As with most things, you find a way of extending them for a little while. I don't think, one of there certainly are children who have challenging healthcare conditions. And we have a medical care system, a hospital system, and organizations that really step up and try to assist in those circumstances. I'm not so sure that we have done as well with youngsters who don't have those targeted circumstances. We understand there's a great deal of economic disparity in our society that really comes home to roost in youngsters. As you will note from the bio, I serve as a member of the New York State Board of Regents. So I see this from the educational side of youngsters coming into the school system. We're looking at a universal pre-K program and more focus on early childhood education. I would think to any of you, child health, child development, the linkage to education, the capacity to support families, this is all very interesting space that I think could get a great deal of attention in the next couple of years. It's certainly something that I care a lot about.
And I would also add to the important points that Jim made, the issue of integrating and ensuring for children, integrating primary care, general health care, and mental health or behavioral health care issues. And the fact that while New York is probably one of the leaders in terms of child health insurance, there is still an extremely underdeveloped mental health system for children. And that also plays, I think, and will play an even bigger role in the areas that you talked about, Jim, in terms of education. Because that becomes one of the major challenges as to how, in fact, to engage youngsters and their families in an optimal way in the education construct for those youngsters who have psychiatric or other mental health conditions. That's a big issue for those of you around the table whose organizations are focused on children. All right, other issues? Thank you very much. So, integrated delivery systems or integrated service delivery systems. Most of the questions related that are under this big trend have to do with the emerging performing provider systems under the Delivery System Reform Incentive Payment Program, or DSRIP. Now, it has become a verb in my world. We are all disripped because of the work that we have been engaged in the last more months than I'd like to count. But everybody is talking about integrated service delivery systems and PPSs. And both Jims have touched a bit on this because the issue of having appropriate and developed enough service delivery networks or provider networks at a time when you are increasing the opportunity for insurance coverage or insurance is so critical. And Jim mentioned the importance of health information technology in making sure that healthcare providers are linked and services are integrated. But I would challenge you guys to talk a bit about integrated delivery systems and perhaps not talk about DSRIP, because I think the aim toward integrated delivery systems predates DSRIP, but then talking about DSRIP as an opportunity.
So why don't I start? Lots to say here. I mean, clearly we're moving towards more integration, and I agree. It started with primary care or health homes, and then there were and then the real health homes that came out of Medicaid, and now these integrated service delivery. And as I see it, what's really being encouraged is for providers to be vertically integrated. So to make sure that if you're a hospital, your relationship with primary care providers, with behavioral health providers, mental health, substance use, and nursing homes and home care. So to have sort of the full spectrum that you can deliver. And so I am glad I don't work for a service provider, but they have spent their life in the last 6 months or a year trying to put together these networks and without really knowing exactly what they're supposed to look like or what they're supposed to do or how you go about sharing resources and responsibilities. So they've been out there. It's been full employment for consultants. I know that. And they're out there. Now, it's interesting. When I look at all this, and you try and make sense of it, and by the way, I really recommend the Medicaid Institute in Jim's shop has put out this nice 6-pager that really describes what's going on with some of this and which of the 25 performing provider systems are doing which types of things. It's a really nice guide. But anyway, when I look at the essence of this, I think that a lot of what this push is, and what the $5 billion is pushing, is to try and address how to better manage the care of the most needy people in our state. The 20% who spend 80% of the resources. And those are the folks who have mental health problems or substance abuse problems, and they have chronic diseases, and the integration really matters. And so it's interesting how I would have thought health homes could have done this, and that a health home would have led to these integrated systems, but the state has really doubled down on it. And I think that, so that's what we're doing. We're doing this. Now, I think there are a couple of issues here. One is that most of the organizations that are leading these integrated service delivery systems, right, are hospitals. What is it, 20, 22, 23, 24, are hospitals. There's one community health center that has the lead, which is a very special community health center, actually. And so it is an interesting question of how much of the resources will go to primary care and how much role that will have, or and the goals that they have to achieve are about reducing readmissions and reducing emergency room use. So I'm worried about sort of how this will play out in terms of the ratio of resources going to primary care versus the back end. And I think a lot of the folks who are really needy need good primary care. So that's one interest. And I just want to make one other point, that it's very interesting how part of the system is moving towards this integration and trying to organize care for the most needy. Meanwhile, we can't walk around Manhattan without running into an urgent care center. They're every other block, and it seems. So for the less needy, we're doing anti-coordination. And we're going towards sort of very readily available, non-continuous types of care. So I think it's interesting how we're moving in these two directions at the same time. And maybe it's not such a bad thing. Maybe if you're really healthy, but you need a immunization thing, you can go to urgent care center and it's fine. I don't know, but that you don't need much coordination. But I do find it interesting that we're not all getting integrated, just some.
Jim?
Thank you for the plug. UHFNYC.org or MedicaidInstitute.org. We use both websites. Bob, we're just, how many days? 3, 4, 5 days away from publishing a review of convenience care, which is essentially the development of the urgent care centers and also the development of care centers mostly in the retail pharmacies. With the support of the New York Health Foundation and our staff, colleagues at New York University. Introductory piece on this. It'll be out next week, and keep an eye on it. Let's step back. We talked about the insurance coverage. You're sitting in the White House in January of 2008. The economy's going to hell, and the president during the campaign says, we're Democrats Democrats were going to work on insurance coverage. And we're going to double down on that, even though the economy is giving us all sorts of stress. Why? Because the cost side of healthcare is blowing out all of our national financial projections. Back to the work of the Commonwealth Fund, in which there's all the other countries in the world growing like that, and then there's us, both on dollars per capita adjusted or share GDP, 17% and change of GDP, but we're heading up to 20 or 22, depending on the out years, as Obama White House looks at this issue in January of 2000. I think I said 2008 to 2009, because the election the crash was in 2008. So in January of 2009, it is the economic team in the White House that goes into the president and says, you got to do this. And says it because you are blowing out our federal financial estimates. You're giving us an uncontrolled deficit and debt. And we haven't even gotten to think about what happens when we get the boomer generation, not only getting the demographic costs that are associated with the larger, but if then you put 2 or 3% of GDP or above GDP growth on healthcare costs, this gets to be a very big number very quickly and frightens the devil out of government financial planners, and to a degree frightens the devil out of the market, and also frightens a whole lot of conservative politicians, but they don't know what to do about it. That was an editorial comment. I welcome the interaction. I spent a long time in the sharp elbows of politics. So what are we going to do about that? Well, you look at it and you say, you know, purchasing each service individually, we do price things higher. Price is a subject that's higher in the United States, but pricing on an individual basis per visit, per test, per whatever, per procedure, if I'm going to pay you according to an individual service, then I'm going to get more services. Economics 101. And therefore, the question is, how are we going to address a question? Philosophically, do we want to regulate? Don't we want to regulate? But even among the regulators, and I put myself in that category, I'm skeptical if I can really deal with these issues through regulation. All of a sudden comes along some health services researcher, Dr. Berwick, Don Berwick, in the lead, other colleagues, the RAND Corporation, comes along and says, you know, depending on the number, 30% of the services that are provided don't necessarily provide value. The Institute of Medicine of the National Academy of Sciences labels this waste. Waste or not, it says if we actually may be able to restrain our cost growth and help finance our insurance expansion from within our existing estimates. How you do that? Well, you've got to create a vision that is not driven by units of service or by price, but that is driven by outcomes. You have to hold people accountable for the totality of the services. And how do you do that? You don't do that one doc at a time. You don't do that one visit at a time. And so the theory of the integrated delivery system, and kind of understand this at 2 different levels. We are thinking about individual providers of care working in teams, and we call that a medical home, or in a primary care medical home, where you're going to have access to a primary care physician, but there's going to be a nurse practitioner who's going to be there. There may be a nutritionist. As we get into some of the more complicated space and understand the behavioral health is an issue, there's going to be a psychologist, a psychosocial worker, either there or available. I'm going to think at the provider level about teams. If I'm inside a hospital, I'm going to be thinking about teams of people working on things. And then at the second level of integration, we're going to have organizations that are going to be working together. Hospitals are a very central part of this. But hospitals now are linking up, as Jim indicated, vertically integrated with front-end services, with post-acute services, and with another whole range of services. And I simply conclude, big change in New York in the last 5-6 years, partially through DSRIP, partially through other market forces. We are seeing an emergence of basically 5 major integrated delivery systems headed by academic health organizations: North Shore LIJ, Montefiore, Sinai, New York Presbyterian, NYU, and then also a very critical part of services, our nation's largest public hospital system.
Our nation's largest municipal integrated delivery system.
And then translating, because it is part of this same trend line. So I've got 6 major systems now delivering downstate services. There are clearly outliers. There's lots of other services going on. But it fits the logic of a change model that is, why is one of the things that Obamacare is hanging in there? It's because 4 years in a row, we've gotten the lowest cost growth since they started counting the numbers. Is it totally attributable to all this? No. There was a downturn in the economy, but we're coming up out of that economy and we're still holding the cost growth down. It's going to go back up a little bit. It's not going to go back up to the kind of numbers that you saw previously. We are still now at 17.9% of GDP. That's where we were when we started this conversation. If you take the delta, the projection of 10-year cost growth on the day that the president introduced the bill, and the 10-year cost growth projection I'm working with now, the delta is $1 trillion. That is already booked as a cumulative savings in a system. That's a really big deal. And it's one of the reasons why we now can argue about a lot of other things as a society. And we're not out of the woods in this debate, economically or politically. But this is a major play, just as the insurance coverage is a major play.
And I think there are some key words that both the Jims have used. I think the most important thing that's not necessary that apparent in all of the discussions around integrated delivery systems and the PPSs, or performing provider system discussions, and the marriages that have been being made over the last several months. I think it's about accountability, because at the end of the day, the payment that will be made, or the funds that will come through the DSRIP program, this is a reform incentive payment program, and that's the intent, will be based on the achievement of certain metrics by those PPSs, and the contribution of all the members of any given PPS or integrated service delivery system will be important. And so I think the other point that these gentlemen have not raised, and I will, is that this is one of the biggest redistribution of funds that I have ever seen. Because as the guy who robbed the bank said, or as when people asked, why do you rob banks? Because that's where the money is. Why are hospitals the center of these PPSs? Because that's where the money is. And the expectation is that that's not where the money will stay. If in fact these hospitals that are leading these PPSs are going to achieve the aim of receiving those incentive payments, some of those funds will need to be redistributed to build up, to invest in those other levels of care, direct health care, but those other services, some of which are those provided by community health workers through CBOs, those support services. That's where the investment's going to need to be made in order for there to be, we move next to the next area, real effective value-based payment approaches that also end with people getting the care they need, and there being better outcomes for people and improvements in population, not just individual patients, but improvements in population health, in community health. And this is the connection of the dots, because I think number 7 on the list of big trends is health disparities. But Jim, you talked a lot about this before we turned the deck to this page, Jim Tallon. Jim Knickman, would you like to talk a bit about payment reform, if there's
Sure.
anything else to
Can
add?
Can I, before you go, I want you to just do one more thing on integrated delivery systems before you
Sure.
leave, because you raised very important questions, and say to
I'll go
people,
back.
what are the issues going forward? We really have the organizational framework that has emerged. I've just described this in New York. The 2 to 3 year question is, how the devil do you make this thing work? How do you actually, operationally, day to day, with the patient, with the provider? I mean, a friend of mine who provides services in the city said, I know how to put a doc in the office, next to a nurse in the office, across the hall from a psychologist in the office. I just can't figure out how to get them to talk to each other in a language that they will all understand. So there's a huge amount of work that is just basically, how do you make this work? Right? And will it work? And there are people who simply say, you know, we're doing the grants, we've got it all on paper. There were endless webinars. We put out a piece explaining it, and does it work?
All the contracts are signed.
The contracts are signed.
Not
Okay.
quite.
So that's the 2 to 3 year horizon. The 5 year horizon is, what does this do to the delivery system? Let me go outside the city and I'll go to Monroe County, Rochester. And where I have the DSRIP program under Medicaid looking to integrate services in a coordinated way, but I am not interested, as a matter of public policy, in creating a singular monopoly health provider who I assume will immediately drive me off the cliff in terms of price. So how do I figure out how to get providers in a community integrated, cooperative, collaborative, working around specific projects, and from the commercial insurance side, maybe even from the Medicare side, and we haven't gotten into the accountable care organizations, another version of integration. Am I going to be running an integrated system next to a competitive system with the same people? That's the 5 year thing. And then the important issue, who's going to run this? We have a system, a not-for-profit system in New York, in which we build our hospitals with trustees and the like, and we've depended a lot on public sponsorship, not-for-profit sponsorship. We have not been big in the proprietary side in New York. Now, who actually governs these things going forward on behalf of a broader community? So I just want to, as we're going forward on this, third question, and I leave with this, who the devil is going to explain to the public what these things are? Okay? That is a real horizon question, because we're all sitting here and saying, and if you think they don't understand Obamacare, try this one. And so, again, I would say, you want to put a marker down, this whole issue of how the public and how people understand that some of these changes, why are we doing them? What are the real problems? What are the real opportunities? Those are real horizon questions.
Yes.
Yeah. So a lot of small community-based social service and sort of ancillary to the mainstream healthcare system agencies are being swept into this. Potentially, if they're strong performers and if they can work the network, they have a lot to gain, and they have a great service to add to what the PPSs ultimately have to deliver. But there's real challenges for that large swath of agencies that have been sort of swept into these applications, where they will, in large part, stay with a very uncertain what that means for them. Money, no money. Referrals, no referrals. Expectations to get to this level, but maybe nothing to come of it for them. And this is a very large part of our nonprofit care and support world. It's not mainstream healthcare, but we're trying to make it part of mainstream healthcare. We're trying to weave it a place. But they are very different agencies. They're smaller, their infrastructures are smaller, their internal systems, their financial tracking, reporting, everything systems are weaker, but they do have a role to play. Can you just comment on sort of mainstream vertical healthcare and this swath of social care and support around them?
And of course, we didn't talk probably enough about that, but there is this whole movement that we need to invest more on the social side, especially for the most needy people, and that so supported housing might be more important than getting one more MRI by a long shot. And it is complicated because I think that a lot of these smaller agencies they don't necessarily have good evidence that what they do saves money, which I guess is ultimately is going to be the big thing, and so it's going to be difficult to understand. I mean, look at care management has been studied with hundreds and hundreds of millions of dollars of studies, and I'm not sure we really know enough about even that, but a lot of the ancillary services that these small agencies do. So it'll be interesting 5 or 10 year period to say, how do these agencies prove their worth? And maybe as philanthropies, we need to play a role in that of helping figure that out. And we do need to figure it out because we can't support every idea, have people riding horses because it makes them less depressed is my favorite. But I get like 2 or 3 of those proposals every year, and yet maybe riding horses does make people less depressed. I don't know, but we have to figure that out, and so I think that is a big challenge.
But let me.
And it's also it's the mechanics of payment.
Right.
They were in a business of billing people for a direct service. They are now contracting organizations in a larger entity. And so, as I say, the 2 to 3 year thing here is, does it really work? You've highlighted one of the big questions. There are agency after agency. They are absolutely critical to our dealing with persons who are chronically ill, and that front end service has to be there. And it's a completely different payment model. And a very simple thing, pick a person out who runs one of these agencies who simply says to me, what I don't have is the money in my budget to actually just redesign my business function. And I have to bill for something different at this point. And anybody who has some money, I can only get.
But I would go further to answer your question as to the challenge facing the community-based organizations. Because many of them are not in the business of billing for their service. They don't have an infrastructure at all about billing for service. They get a contract, they get some other support, and they conduct their services. That is, it's like we, and I'll speak for Health and Hospitals Corporation that has, I've lost count as to how many CBO partners we had in our application. Our disrupt application, I know it was more than 100. But we, as large hospital systems, have included these smaller organizations now in this PPS. Frankly, probably because the state told us to do it. I don't know that anyone would have been as aggressive within the short time frame that we had and as expansive in engaging CBOs if in fact it wasn't a requirement. I mean, HHC had pre-existing relationships, but I can tell you it wasn't with the number of CBOs that we now have in the PPS. But it's like we're bringing people in to a wholly different culture that speaks a wholly different language, that has a wholly different set of rules and expectations, and then we're going to expect that they swim. They are not going to swim. And so the challenge for the lead of a PPS is, what do we create as an infrastructure to support these new family members? I'm not sure the North Shores and the Presbys and the NYUs and the Maimonides, the PPSs, I can only speak to New York, even know how to do this. That's my point. That's exactly my point. There is a huge opportunity for philanthropy to support those organizations in entering into a new universe and helping them develop a skill set. And I would say concretely that some of the more forward-thinking CBOs, and I include CBOs, when I used to work CBOs, I include those community-based organizations, but also include the community mental health agencies, housing organizations, organizations whose whole tradition has been to provide support services for persons with disabilities or families who have children with disabilities or children. To help them, some of those organizations have formed or begun to form collaborations or coalitions, and to put together their resources to figure out what kind of infrastructure they could invest in a shared way to live with or be in this new big family. So one of the things that you guys could do is maybe figuring out how to help them do that in a sustained way so that they can be viable in this new world. We need them, but we don't know how to help them necessarily. We're all going to be struggling with this together.
It's interesting, we don't have it on our agenda, but you have the same conversation about organizations and agencies that are working on population health and prevention, and where do they fit into all this? And that's another one of how do they muscle.
Yeah, and I think, and I'd say that those hospitals, included the CBOs because they were told we had to. I mean, HHC is a huge integrated delivery system, but we weren't enough of an integrated delivery system according to the state, because they said no matter whether you have hospitals, health, ambulatory care centers, community-based healthcare centers, a nursing home, a health plan, a home health organization, that's all that we had. They said that's not enough. You need to have more CBOs. So I would say to you that it's important to help those organizations really gain the strength to be able to succeed, because one of the reasons they came in was because they heard the state said there's money in them our hills, and they're losing their sort of foundational funding sources as well. I don't mean foundation in that way, but like their basic funding, and so folks are desperate to become part of something new. But this is, as my colleagues here said, this is a huge experiment. And we really want to work, and we need, therefore, all the parts of this ISDS to work, or PPSs to work, and to be strong. Dave?
I think it's a moment of fraught opportunity for the CBOs. But to pick up something you said at the end, which is why I was nodding my head, which is that the financing for those CBOs is contractual, and it's limited, and in fact it's been shrinking for 20 years. The new money on the table is with the healthcare system, and I think it's great that CBOs are being invited, as it were, to the table. The thing that I think that's all good. It's all fraught with some difficulty, and some will succeed and others won't. Jim's comment about evaluation, Jim Knickman's comment about evaluation, is again a concern, because I don't think there'll be many examples where a CBO is going to be able to demonstrate that its provision of services contributed, with some R square to the reduction of utilization. And we've had some experience with this with the Hospital Funds Project in Washington Heights around seniors with diabetes. What they can demonstrate is their effectiveness in service delivery, their efficiency in service delivery, their ability to really work within a system, because then I think there's going to be just an enormous amount of noise as to what really is driving either increases or decreases or stability in cost. So the evaluation question, I think, is a difficult one, and we ought to, and again, it's a place where I think foundations can play a significant role, but I think we ought to approach it very carefully and not get swept into, well, show me your outcomes and show me how your provision of that meal program, reduced emergency department utilization. But the conversation actually gets almost as precise as that and unanswerable.
Well, it's tough. It's sort of you have to make your case somehow, though. I can guarantee there's going to be a lot of people trying to make a case, and R squared might not be the case, but
Jim, I just wanted to add Corey Reeder at the Hartford Foundation that Hartford is working in this area very closely, partly with the administration on community living and helping contract between social service agencies and health organizations. So if anyone has an interest please let us know.
So payment reform?
Yes, payment reform.
So payment reform, we'll see if we get through all 7 of these.
I'm not sure we're going to need a time check.
So we finished 2. Okay, well, I won't say a lot about payment reform now. I understand, right? A payment reform, clearly is where we're going, I think, in the state. And in some ways, if you talk to Jason Helgerson and others at the State Department of Health, they'll say we have to get these PPSs designed and put together so that we're ready to offer payment rates that are more value-oriented or more sort of not paying fee-for-service, but using other approaches that incentivize people to use the right care and the right amount of care. So I think that's and the newest pot of money from the federal government, $100 million, is partly about really investing in payment reform. So I think we'll see a big dose of that starting in the spring and figure out how to do it. So a couple things to say is I think that payment reform, we have to get new incentives. I think everybody agrees, even providers, that paying based on volume, just the more MRIs you do, the more money you make, just doesn't make sense, and it isn't working. But then the question is, what do you replace it with? And I think that'll be an interesting debate as to how you go about doing it. There are all sorts of possibilities. There's capitation, the broadest. There's bundled payments, which would pay more of a fixed payment for maybe an open heart surgery, or a fixed payment for managing somebody with diabetes for 4 months. So you could bundle things a little bit more, so you have incentives to be efficient in that bundle. There's shared savings, just somewhere in between, where if you reduce your costs, you get to keep a share of them. And there are caps, which is the one thing we have done in the state of saying we have a Medicaid cap of 4%, I guess, a year. And Massachusetts has caps, and other states are starting to do that, where you just say, you have to live within that cap, but if you don't, we will take some drastic steps to force you to come in at that rate. So there are different mechanisms, questions how to get there. I think a few things. One is it needs to be all payers, I think. It's crazy if one payer has one set of incentives, a second payer has a different set of incentives. I mean, you're a physician saying, okay, this time I'm supposed to maximize the number of MRIs, and this one I'm supposed to minimize the number of MRIs. I mean, it's just crazy. So I think the state in its powers can bring all the payers together, and that should be a goal. I think the other thing that's crucial here is, again, it seeps in everywhere, is the importance of data in IT in all of this. Because in order to really figure out what is the right amount to pay, you have to understand what services cost and what services are received. And as a provider, you have to have the data to say, what is the total cost of care for this patient, and what's in there that I could take out? And remember, if you're a primary care provider who's accepting value or capitation, a lot of the services are not being delivered by you. They're being delivered by the specialist of the hospital. So we need these all-payer data sets. We need these cost of care data sets that will allow everybody to have a better hold on what the costs are and what the outcomes are associated with different approaches. So I think we're there. Our foundation is helping to build a Medicaid total cost of care data set that NYU is actually producing, that I think will be very valuable, and it's going to be very usable and accessible to both researchers and to providers who want to better understand what's going on within their practice. We need to get to the all-payer data set, which is really what you need, and eventually, I hope in my lifetime, we get to having electronic health records that also can be linked to this data, because that has the real data about outcomes and about what actually happens. So.
Jim covered it really very well. Just inside the mechanics of this, if you're on the provider side and you've integrated, you're going to wind up taking degrees of risk from the payer. You're going to have some of your incentive not driven by the volume of services, but by another alternative, whether it's outcome or whatever. And I'm going to assume you're going to give me a broader payment for this patient, and I'm going to assume some risk, some financial risk, upside, downside risk, and learning how to do that. is going to be a very important challenge. It's a fairly technical space, but it is a space that clearly the Medicare program, a lot of the private insurance carriers are doing for their own lines of business. They tend to be fairly not only independent from the rest of the system, but they're independent one from the other. In some sense for antitrust reasons, but in another case because they, I mean, ultimately staying afloat in all this business is, can you do a good job, but can you take a little business from the other guy? And so, I mean, but we're going to learn more about how to share risk. A couple of the big systems now have talked about creating their own insurance companies. And there are 2 systems in New York who will be operating captive insurance companies. That's a portion of how do you share the risk within yourself. The Geisinger Medical Center out in Danville, Pennsylvania, developed a captive insurance company, and it wound up looking at a lot of really innovative payment systems that it did with its own insurance company. And it had maintained traditional relationships with everybody else, but it could get down inside how much is my insurance company paying for my delivery system, and how do I build the incentives on both sides. It works a little better when you own both sides of the system, but that's all part of and the whole picture of all this is optimistic space, because we're working on one of the nation's most challenging social and economic problems, and people are talking about how to do it better. That's a big plus.
We should move on, but payment reform won't be easy in New York, though, because we have so many things mixed in with payment. Medical education, charity care, and so whenever you start to look at these numbers, it's very hard to work out what are real costs, what are the added costs. Ken Rasky was here; he'd explain all this to you. Anyway, so that makes it that much more complicated.
I think it'll get more complicated based on what we just talked about in terms of these performing provider systems, because we're adding additional types of services or inputs to the cost. And so I think, again, that's space for this community to be looking at in terms of what, an assessment of the different types of constructs. Jim, you talked about Geisinger and the captive insurance. We've had our health plan for 2 decades, right, and we've had global payment arrangement with our own health plan. And so we understand the incentives because they're able to reinvest in our system and actually pay for some things that aren't reimbursable. But when you then include other organizations as part of a PPS, how does that fit with a global payment arrangement with a health plan that's owned by one entity within a PPS? Or, you might end up with a PPS that has multiple payer entities because of who's in that PPS. So this is, something that those folks who are smarter than I, maybe from the Institute or from the New York State Health Foundation, David, might be looking at in terms of those different types of relationships in the era of DSRIP. Hospital sustainability, another big trend, or one could say hospital non-sustainability. So the big question is, how can the stability of hospitals and health systems, particularly, I insert this, those that are safety nets, those that play a safety net role in communities or in large swaths of geography and other than New York City, be sustained throughout all of this change, or with all the things we talked about, to ensure that there is in fact access to health care in a particular geography for all patients.
Since he has hospital in his name, you should start.
Jim Tallon.
No, we should have changed that. Well, first place, the really challenging thing, and probably now I'll look at my public information person, I'm going to get in trouble on this one. The question is just not a relevant question anymore. We're into a post-hospital generation. And what I mean by that is hospitals are critically important in the totality of care. But the big building on the corner, the big box, is not going, we are not going to have the number of hospital beds per capita that we had 15 years ago, because we don't have the number of hospital beds that we had 15 years ago. Why? We have shorter lengths of stay. Why? Because we don't put great big incisions in everybody for a surgical procedure. Now we do it. I don't do any of this stuff. And, you know, the heart attack that laid in the bed for 2 weeks, who was my father, is not the treatment. So much is changing. And the role of the hospital is changing. I think the futurists in this business will say the really intensive inpatient experience is something that could become very sophisticated and very costly, but for a relatively small number of patients in the course of treatment. The way we're thinking about it goes back to the question before. We're thinking about this as an integrated system. What we call a hospital is a line of product or a line of business or a line of service in an ever-changing system. This is the place probably where the political debate is furthest away from the system reform debate, and understandably so. You talk about closing a hospital, everybody kind of grabs their chest and thinks, what do I do if I have an emergency? And of course the health system answer is, well, for God's sakes, don't go to the place on the corner that's not equipped to handle your need. Let's get the transportation system that will get you to a place, but more importantly, let's make sure that that first contact that you have as soon as somebody can get to you is very sophisticated. And then even getting back further, let's train all of us in the kind of equipment that may be available in our workplaces to deal with that image. So, you know, we live with our history here. Clearly a very practical challenge, and something I look forward to working on is this is a system that needs people. It's going to need people in different job titles than what they had previously. I mean, for example, there's a whole cadre of new employment needs in the healthcare system that relate to the interpretation and movement of information. And so there is a huge workforce opportunity here as we change the nature of the system, we integrate it further. And I do know the frustration that exists. Hospitals, we made a choice in New York, and I think it was the right choice, that we're building this next generation around the strength of a hospital community that has been core to New York. But it's a changing environment, and it's simply, and the public, this is probably the place in which average folks who do other things with their lives, which is perfectly reasonable to do, we probably need to spend a great deal of time understanding what the future of what we call the hospital is. It's going to look very different.
Rachel?
So, when this topic comes up and the reduction of beds comes up, I think about the Bloomberg sort of social investment project around recidivism, where Bloomberg partnered with Bloomberg to essentially hire an agency with an evidence-based model that would reduce recidivism, working with the prison population, and because the city prison system knows that if the recidivism rate drops by X number, so that they have a reduction in prison population of X number, they can close a wing. When they close a wing, they know exactly how many dollars they save. So, well, yes. So, but the problem is these big box hospitals, the physical plant does it make it so easy to just spin off, Brooklyn Heights condominiums? Maybe some of them can, right? But so you may have, a floor that suddenly has a third of the beds empty, and maybe that's a good thing in terms of health reform, but it actually doesn't really it saves the system money, but it doesn't actually save the hospital money if you're still paying maybe somewhat. So help me on that. I don't understand how the big boxes survive when the beds reduce, which they need to and should.
If I'm dealing with a system that has 10 hospitals, then it's that system, and I'm not pointing at the system to my right, is going to have to say, is this whole unit in service? What's the alternate use for the physical plant? What's the alternate use? You don't.
Let me give a real example.
At the margin, it's a lot tougher to reduce costs. You have to take units out of service.
You can't close a half of a floor. You can't even close one unit. But what you can do, which is something that we've done, is when you're engaged in a large capital program and you're looking at total utilization, and as Jim said, you're looking at less HIV cases, you're looking at technology that has reduced the need for certain length of stay, etc., and you have a 20-acre campus with 15 buildings, you consolidate that campus to 2 buildings, and then you have a huge parcel of land. In our case, we've actually partnered with some for-profits and some non-for-profit organizations for them to use that land to build housing. A mix of supportive housing for our patients who we want to keep out of the hospital, and we've been in proportion less successful with as much of that because of the NIMBY, frankly, the community boards who don't want just folks with special needs in a building, and with mixed housing so as to contribute to the administration's aim for affordable housing. So you can do those things. But I have to tell you that that's not, and you're right, the administrative overhead cost just gets covered, having to be supported by a lesser base of operations and revenue. You deal with that. But the biggest issue, and particularly for safety net hospitals or health systems, where they are the largest employer in their community or in their town or in their county or multi-county area, the big issue is the issue that Jim raised, and that is the workforce. What do you do? Because to your point in terms of social impact bonds, not only do you know how many less prisoners you're going to have and how many less units you're going to have, you know how many less correction officers you're going to have. You know how many less of whatever else you're going to have. And with hospitals, we need help in making that transition with what are the alternatives that can be put in place to redeploy, retrain those people who, in our case, as an example, Kings County Hospital, 60% of the people who work at Kings County Hospital Center in Brooklyn live in central Brooklyn. They put their kids through college based on their employment in this public hospital. And I would dare say for some of those other non-public safety nets. What do you do in terms of a workforce? Big challenge for you guys. Help us figure out what the new workforce should be, how to retrain people, as well as how to create new people, new skill sets for new workers. That's the biggest issue, and that's the political issue. Hospitals don't close because they can't close the building. They close because labor unions say, what about my people who have these jobs? That's LaRay's commercial.
Can I just,
Yes.
Since you raised the issue of workforce so eloquently, LaRay, there is also the issue of the unpaid workforce, the family caregivers
Absolutely.
who are basically taking on being the work that has been done in hospitals. It's not just the smaller incisions, Jim. We can do this at home. You can do this, dear. If you take your mother home, we'll show you how once. We'll take you, you can do it at home. So the unpaid workforce, which is huge, and in New York it's probably at least 3 million, but probably more, family caregivers, is really not factored in to any of these discussions I spend a lot of my time raising either my literal hand or my electronic hand in conference calls saying, family caregivers, because we are the backup for all of these systems. And unless there's more attention paid, the systems will not be able to do the community care, will not be able to be the coordinating care. The other point is, yes, the hospital beds have been decreased. I have heard and experienced, actually, with a relative, people being in emergency departments knowing that they should be admitted. Doctors all along say, you have to be admitted, you have to go to the ICU, but we don't have room now. I mean, this is another factor that really does affect the care of real people who are in need, should be able to get a bed if they're not just because it's not a wish, it's an absolute medical need.
Just, do you all want to comment on the family care?
Only, I
piece?
don't know if Carol introduced herself.
Right.
Carol Levine, who heads
I would say
the family
on
caregiving.
that, if there's a trend that you can identify in that comment.
Well, I work with Carol every day, so the trend clearly a number of years back, she identified this particular issue of family caregiving, which is a long story, and Carol Levine is worth getting to know on this subject. I think that we probably have helped over the years now in getting people to think about patients and caregivers. I think there is a level of recognition, whether there is, Carol, we and you find it an ongoing challenge, and continue to remind people just the level of sophistication that is expected in the care that family caregivers are giving. The family caregiver ought to be envisioned as an integral part of the healthcare team. On the bed supply question, that is clearly a distribution issue. In the aggregate, for depending on, we'll get into respiratory infection seasons and things like that, we'll get some unique fluctuations. I started out my career as a health planner and used to be able to, in fact, perhaps one of the first health planners to use a square root in a formula. That got to some randomness in the assumptions. The supply in the system and the distribution of that supply, part of that is related to our helping people understand when they ought to be using ERs, and obviously creating some of the alternative, whether the urgent care centers, the primary care centers, all the alternatives that are out there. But the family caregiving, absolutely essential that everybody understand, and there is lots of space in family caregiving for better improvement of what we do. If anybody's looking for a bright idea, we have somebody over here who can really tell you about it.
All right, so another big trend, or imperative really, is as all these changes are going into effect, as all the imperatives in terms of reducing cost, bending that curve that Jim talked about, in terms of the how the U.S. healthcare system's costs affect the GDP. The big question is, will these changes affect quality and safety in patient care? And I would say, have they? Is there any evidence that that there has been an impact on quality? And I'm not suggesting decrease or increase, but specifically, has there been an impact on quality?
There's been a dramatic change in the insurance coverage side. There's been a dramatic change in the cost trend. There has not been a dramatic change on the quality and patient safety side. Is there improvement? Sure. But is this a place now, as we're thinking about how new service delivery systems work, how do you step back and independently make certain that we are having constant pressure on quality and patient safety, supporting this with the engineering work, the system science work that needs to be done to actually lift our level of performance? Every complicated sector of society and industry works in this space. We in healthcare have not moved as aggressively in this area. It's a place that we'll be taking on some new initiatives at United Hospital Fund, where actually we are identifying it as a data analytics issue. This is a system now overwhelmed with the indicators. The state, we're going to sign a contract with the state to just look at a couple of hundred performance indicators that they have, and we desperately need to synthesize that down to a workable number so that the people in the system can work with it and the public can understand it. We probably need to educate and support a group of professionals in better understanding quality and safety. In the center of some of our most sophisticated hospitals, there is just incredible talent. As you get further out into the long-term care side of the system, fewer people simply trained in the techniques of quality improvement and patient safety. And again, the public still has a modest understanding. You know, the first thing we probably tried to do was give people report cards, and I think by and large that is not a useful way of getting to people better understanding some of the variation in the system. But as we go forward, we're going to continue, we need to continue the downward pressure on cost growth. It is increasingly important that we have the transparency and the focus on quality and safety. This one's going to be a big play in the next 5 years.
So, just a couple of, but I'll start by saying I'm amazed that we made it through hospital sustainability without mentioning the word Brooklyn. But
That's just
that's
one
a
borough,
special-
it's not a trend.
That's right. So a couple of things on quality and patient safety. I think I agree with everything Jim said. Honestly, it's you know, we should be able to do this. We have much better data. You know, within hospitals, there's excellent data. And so there's no excuse not to do it purely in the hospital setting. I'm very concerned about the more primary care and physician, small group settings, where it just seems almost random what people, and it's not even just making errors. It's just sort of, you know, what people are prescribing for different things. And I think part of it is a patient communication, a patient-doctor communication issue often where, you know, a patient is not really explaining their symptoms so accurately, or doctors are not asking questions, or nurses or whatever. And so it's that's part of it that I think we have the most to make up in terms of quality. And I think any of us, maybe it's one of those things where you're a haughty New Yorker often, but boy, when my relatives around the country call and say what their doctor said to do, I say, oh my goodness, you know. And I think part of that is this idea that medicine is an art and everything's different. And I think we have to challenge that a little bit more and find out exactly which part of it is an art and which isn't. And are there ways of having prompts and reminders and all that. But anyway, I think we have a lot to go on that side of it. I think any payment reform has to be about payment and outcomes, you know, and we can do that now, and we should do it, that you don't get the shared savings and you have bad outcomes and things like that. So.
You deal with nuclear power plants, you deal with aviation safety, you deal with any number of complex issues in society, understanding that there are elements of personal preparation, qualification, performance in this. Maintaining, improving quality is a system characteristic. It's an engineering challenge. And so many of our big healthcare systems are moving into this space, as Jim indicates. As you get out to the periphery, and I don't mean that in a disparaging sense, just getting away from the center of the most intense parts of the system, there's a lot of room for improvement. And with people, it's a matter of understanding that, you know, whatever we say, all of us don't go to the best doctor in town. That is statistically impossible. And
that's not what the magazine said.
And you know, and when we walk in, that, you know, that question of how do you make certain that the prescription that has been written is in fact the right one a lot of learning here, and I have found some of my most exciting conversations with folks in engineering faculties who are starting to move into healthcare space.
Before we move off of this, and we are coming to the 6th and 7th issue trend, but I think another aspect to consider in this space is how, and this I think is something that those of you in the room can help. As a healthcare consumer, it is, I think, consumers are being bombarded with data and the U.S. healthcare report or the consumers, digest and the best hospitals and the best this and the best that with data that they don't understand. Or they understand it because New York Magazine said it were so. But one of the big, I think, opportunities is how, not just the transparency of quality and safety data, but how can consumers use it in making healthcare decisions? And that's I think, a huge opportunity for the folks in this room.
Mm-hmm. And it's interesting, at least for some folks, places like WebMD and the Mayo Clinic sites, there is information out there that is pretty clear and pretty comprehensive if you use it.
I want to balance that. You're absolutely right, but I also want to balance that when I get on a plane at LaGuardia, I'm not doing a pilot choice. I am going with absolute faith that somebody else has figured out how to get a person who knows how to fly the plane, who is doing the 24/7 to make sure that I am physically as protected and supported as I can be. And so, we can go up to a point with a consumer choice model, but this is an engineering characteristic in a system, and it's the people who run the system who really are exceedingly well motivated. I meet all sorts of people who really would say, would somebody please pay attention to this space, especially in an environment where there's such downward pressure on costs.
Comments before we move to the next big trend?
Just quickly, also to include in the discussion the CBOs and these other organizations that don't have the standards, that don't have the quality measures, and now that they're being included into the array of delivery services, they're going to be held accountable for their quality, and they're not accredited. And this is a huge issue that's coming up that we're looking into.
Also, just remember, they're not the same topic.
It's right.
Quality we will define as adherence to standards. And where we have consensus standards in healthcare that this is the approach you ought to take, quality is fundamentally the adherence to that standard in performance. Safety is the avoidance of error, wherever that error comes from. So, I mean, they're really they're interrelated, but they're really quite different concepts, and they are vitally important to us, both of them.
Patient engagement, it's a nice segue. So how will patients in this very, very and widely, very varied and widely different circumstances of the emerging healthcare delivery system, how will patients be engaged? And I think we've touched on this before in several of the other trends. There was discussion about how do you explain this disrupt thing to consumers. There was discussion about how do you engage individuals who are newly insured around the importance of insurance and accessing health care. But again, the philanthropic organizations could be very important to helping the healthcare delivery system in knowing effective strategies to better engage patients, to better engage family members, caregivers, etc., but also in helping for there to be the best practices of engaging patients in their making their decisions. Jim?
So yeah, I'll start. And this, in some ways, was a catch-all trend. As we put this one together, as you can see, it goes all the way from patients to IT and so on. But just a couple of things. I think it's to try and get to a system where patients are fully engaged and understand. There is this overarching problem, I think, that our healthcare system, for the most part, is not very patient focused. It's not patient centric. It's not patient facing. The automobile industry focuses on people when they're marketing their cars, and everything they do, they're thinking about the people who are going to buy them. Healthcare providers are just as focused on Blue Cross Blue Shield or every payer as they are on the consumer. And a lot of times you actually hear them make that mistake and say, I'm focused on Aetna. And so I think the first thing we have to do is somehow change the world so providers are forced to be focused on patients, just like every other industry is. And that's a real challenge. And I think it's something that over the next 5 years, the public is going to explode. I mean, sort of, what's his name's book on
Brill?
Yeah, Brill has sort of hit and Steve Brill and others have really hit on all these things, and I think that's important. So, and it's interesting. Maybe the good side of high deductibles and copays is that people are going to demand more because they are paying. And a lot of people think the reason it's not consumer focused as much is because people don't pay out of pocket, so they don't think about these things as much. But as we get to a system where people do share some of the burden, especially up front, I think maybe we'll get forced to do that. And I think that one thing that leads to, of course, is I think the other trend that's going to be big is just transparency in general, forcing providers to be clear. I mean, it is amazing that this is an industry that doesn't tell you prices. It doesn't tell you what you're going to have to pay. I mean, this is America. We're all about money and costs and prices, and they won't tell you. And that has to end. And I think that our state is taking is going to be in the lead on this. In April, there's going to be a new law, DFS got through, is going to really take on some of these surprise bills, and there's a whole series of changes that you're going to have to be told if you're seeing somebody out of network. You're going to be told what the price is before you deliver it, and if they don't tell you, they're going to have to charge you the in-network prices. It's a very technical set of things, but there's a lot there that I think is a good first step. But there's a lot more that has to happen, and the publishing of the state also published prices, but those were the rack prices and don't mean anything. But right now, DFS is working on a project, and we're helping on that is going to publish not the exact cost, but we will give you a sense of what different providers are getting paid by actual payers.
And Jim, by DFS, you mean the Department of Financial
Services, the insurance regulators, the payer regulators. Sorry about that. And so we're moving towards getting more information about variations. And there was just something released. I just read something in one of the many things across my desk. I guess one of the big insurance companies out west, published all the rates that they pay different providers, and the variation in what different providers, even in one place, charge are just stunning. And so I think all of that is part of what we need to do on the consumer side and the patient side to make the system more responsive to patients.
Thank you. Jim Tallon, you talked about HIT, or Health Information Technology, and that plays that should provide or be an important facilitator in this area.
Over the next years, we're going to see an evolution of a system in which our medical records become integrated. And clearly there's going to be a big grown-up question there about privacy. And we can build in, and we actually have built in laws that are very strong. I mean, I think we live in a world in which we understand there just is no absolute privacy on any information flow at this point. I'd still rather have the integration of the information and be assured that it's there. We've spent 5, 6, 7 years trying to build an information network in New York, and it's got another 5 years to go. It's a huge effort. It's the most ambitious in the country. The DSRIP work in Medicaid is going to integrate more people into this. So what's the standard? Well, at a point in the not too distant future, when I go to see a healthcare provider, I ought to be able to expect that healthcare provider doesn't hand me the clipboard again. I mean, just think of it, and I make fun with some of my friends in healthcare. Here, can you perhaps provide us with some misinformation so that we can kill you? We actually know what you're allergic to, and we know what medications you're on, but we're going to ask you to see if you can get it wrong. Okay. So, I mean, it's the tradition. We've done it for a long time. What else do you do? But you hand the clipboard. We're gonna get beyond that, and we're gonna anticipate as consumers. You've pre-populated all this, and more that this is the experience that we're having. You walk into settings, and the data are pre-populated. And somebody always uses the Jiffy Lube guy knows more about my car, or at least can tell me more about my car and its recent history than can my primary care provider. But we're getting there. We're moving on that. And that's really happening. State's making a big investment in this stuff, enormous amount of work. It is very complicated to do. It is very complicated to just do the technology to make certain that if there are two people in this room who have the same name, we can figure out which one of you is this person. But there's great potential here and a great deal of effort. I think there's a couple of different levels of this. And Carol has thought a lot about this recently from the family caregiving point of view. There are lots of technology folks who are just absolutely incredible in wanting to show me a device that can tell me more than I ever wanted to know. And what do we call that person? A data phobic or data? I mean, people can get addicted. Well, the people can in fact get addicted if you have something on your wrist that's reading some body function. Some people then just can't stop looking at it, like that other thing that we have that addicts
Should we
us.
see how many Fitbits there are in the room before we denigrate?
I guess what I would say, this is a place where I actually think there's a lot of free thinking. I don't think anybody has got the game here. A decade ago, we had the idea that we could put out report cards to you. And what you found out was that actually on a day-to-day basis, I have other things to do than to worry about the onset of a health problem, which I'm really going to worry about when it happens. So how do you think about this? I think there's some basic things. I'm sure there's a top 10 list that we all know. Does everybody in this room know the symptoms of a stroke? Okay? Because when that happens, this system can save you, but only if you don't put it off. And only if you, so there's some things as basically about our life. Do you know what to do when an unusual, there's some learning things that we could all do. There is, I think, and go on endlessly on this one, which we will not do. I do think of all the choices that are out there, I'm really becoming more aware of the technology. I still need a primary care contact in the system. And I think that in a sense, that goal that we've had for a long time, and it's challenged a little bit by the convenience care, by the urgent care center and things like that. Maybe that urgent care center, if I can link up electronically with somebody who's responsible, we can make that whole thing work. But if I have somebody, when I have a question or when I help me interpret this, that is a critical link, and I think that is still essential to build in moving forward. That as we are so different. We're so different in our health circumstances and our place in life and everything like that. There's not a standardized answer here. We're not going to get this by a series of happy faces on a report card. We're going to get this in a very individualized way, and that's what the technology can do for us.
And last but certainly not least, disparities and the body of work that I believe all of us in this really complicated system need to be more focused on, and that is in addition to making sure that we're providing safe care and that we're adhering to standards to ensure that we're providing quality care. for the person in front of us, that there ought to be accountability for the improved health of the community that we're serving, and frankly, for there to be an assumption that healthcare delivery systems should be serving a community and not just individuals. And what are the responsibilities for large healthcare delivery systems in investments to ensure that people in those communities, regardless of their economic status, have access to healthcare and have access to opportunities for their health to be improved. So the question to my colleagues here is, what changes ought there be in the healthcare delivery system to ensure better population health and reduction, more than likely not the disappearance of, but reductions in the health of groups of people, particularly in this city, which are extremely large. Those disparities are extremely large amongst folks by race, by language, and most certainly in terms of economic class.
Maybe I can start. I just want to make 3 quick points because of the time and want to hear from you also. But first thing is, one of the most fun studies to read, or at least there's a number of studies that have looked at what happens to disparities of people of color versus white people in terms of healthcare utilization pre when you're 65 and post when you're 65. And of course, there's a dramatic increase in health insurance coverage for people of color because of Medicare return 65. It's a dramatic, all of a sudden the disparities in use of health services shrinks tremendously post 65. So we know insurance coverage really matters to getting care, and outcomes, especially for those shorter term healthcare problems, decrease, the disparity decreases markedly after 65. So we've got to hope that the Affordable Care Act and the expanded insurance coverage helps on that. By the way, if you want to evaluate the Affordable Care Act, if we don't see the closing of disparities of use, this is a failure. Because Medicare does it. If this doesn't do it, we've designed this insurance system wrong, and we have to go back and fix it. So I think that's probably the #1 evaluative indicator, which will be easy to track. Commonwealth will do it. The second point is, I do think we've got to focus on health status and not just medical care. And I mean, as a nation, I think we have to just commit to just reducing life expectancy disparities and health status disparities. I just don't see how we can't get to consensus on that. And I don't want to live in this country if we can't. I mean, it's just terrible. And so I think that's the second one. And I think we can take on that challenge. The third one, though, is an economic status thing, is that I feel as if the health, and this, again, was the theme this week in terms of the State of the Union, I just think we are really redistributing money from the working class in this country who have to overpay for health care, partly because of all of us make a lot of money, but surely because prices are so high in health care. And we're giving it to wealthy people. And that just seems so unfair that, again, the people earning $40,000 to $100,000 are just being sapped of probably $3,000, $4,000, $5,000 a year that they shouldn't be paying. And it's going to wealthy Americans. And I think we have to address that issue. It's not just healthcare, it's other parts, but healthcare is dramatic. And I'd say, this is a group of people who haven't seen any increase in their economic well-being in 15 years. And if we could give them a check for $1,500 or $3,000 for unnecessary healthcare that they've been paying for, that would be a huge boost to their well-being. And I think we need to do that.
Just 3, Jim, good comments. One, still obviously recognizing the economic segregation that exists in housing patterns in our society, and then how that translates into the available services and the whole issue of food deserts and the quality of life, and the questions related to physical, environmental patterns. Take a look at the asthma numbers and things like that. So, I mean, the environment in which we live is reflective, or the differences in housing patterns that are driven. I mean, they may manifest themselves in race and ethnicity, their economic disparities, and in multiple environments in which people live are important. Secondly, as you move to integrated systems, if I've got 5 major integrated systems plus the important 6th system, I keep it different because their model and at the academic center leadership is different than the very important Health and Hospitals Corporation, which has the far greater diversity. I mean, the patient comes in and says, I go to HHC and I'm guaranteed to see somebody who looks like me or who sounds like me. If I think about those systems as they're managing their responsibility and recognize these systems, every one of them is going to be spread over 5 boroughs, the suburbs, 3 boroughs, 4 boroughs. If we simply look at their treatment of all their customers and build in the standards, then that's going to have a positive effect. And a third effect, let's come back to the workforce question. Because one of the shocking disparities, again, on the Board of Regents, we license all the professions. And if I look at the racial and ethnic background of nurses in New York City, I'm going to find some disparities. And I can correct that in a very positive and proactive fashion, working with the education system, reaching out, because the youngsters with all that diversity are in our school system. They need the kind of extra support, but looking to make certain that those who are providing services in the healthcare environment reflect the diversity of the communities, race, ethnicity, language, all the like. That could have a very positive effect too. And the final thing is you got to look at the numbers. Got to look at the numbers and tell the truth and do the numbers on an ongoing basis and be open to the question that we are still not achieving. And, look, the good fortune in this city where, we're still living with all our challenges and differences. We're living in a city that believes that this is the right thing to do.
And sorry, Ramon is handing it over to me. So before we end, we're a little bit early, so that we actually have 1 or 2 minutes for questions if anyone would like to ask a burning question on this or a trend that you think should have been talked about today that hasn't been.
Based on the slide before this, in terms of patient engagement, which I think is largely seen as how do persons learn how to become professional patients, and are they going to be literate? Are they going to play with the system? I'd flip it, and I'd say one of the really important themes in terms of person engagement comes at end of life care, and if there isn't the opportunity to have a real relationship between the individual and whatever the clinical team is that's supposed to be providing care, and that they can't have the discussion about goals and repeated discussions about goals as they change, then I think that most of patient engagement turns into, a fairly prosaic economic exercise and doesn't provide the kind of humane care that has significant cost implications and utilization implications, all of which seem to run against the preferences of individuals. So I just would put that one back into patient engagement.
Any other burning questions, comments, thoughts? Yes.
Hi, I'm new to the group, and first of all, I just wanted to thank both of the Jens and LaRay. This has been a fascinating discussion, and I welcome the opportunity to get to know you all. But I just wanted to make, I guess, a couple of observations. That at Commonwealth, we study a lot of these questions on a national and an international basis. And I think one of the things that we've all learned is that insurance is certainly necessary but not sufficient. And all of these questions really flow from that. But also as a New Yorker, and I have had the opportunity to participate on the board of a safety net hospital in New York. In New York, there's so much going on right here in New York, and this is in many ways such an interesting laboratory for all of these questions. And I think, I think it's like the old song, if we can make it here, we can make it anywhere. And I think that's really true. And I look forward to working with all of you around these questions and taking what we learned here and spreading it to the rest of the country, because I think it really is applicable and important.
Was there someone down on the end who wanted to say something, or?
Well, thank you so much. Thank you to LaRay for being a great moderator. Thank you to Jim and Jim. I enjoyed this show and I learned a lot. Thank you, Paul, for contributing.
And thanks to Philanthropy New
Thank
York.
you.
It's good program. Thank you.
And thank you for introducing me to this group. I was getting ready to say, I want to get cards. Because we're that sick system. And yes, there are. I'm serious.
We don't disagree a lot.
Good. Very nice to meet you. Thank you very much. Excellent. I'm really good.